So, welcome our panelists and every observer from all across the globe to the Prince Mahidol Award Conference 2021 side meeting SE11 in collaboration with International Federation of Medical Student Association or IFMSA and IFMSA Thailand. So today's session will be focusing on the topic of investigating the role of digital health in healthcare emergencies. My name is Bhoowit Lerttiendamrong. I am currently the Liaison Officer to Prince Mahidol Award Conference representing IFMSA Thailand, and I will be moderating today's session. So as a moderator, our brief overview will be, I will be laying out the backgrounds for today's session, our session's objective, and then our panelist introduction one by one. So let's start off with some backgrounds and definition on today's topic. So health emergency is an acute high impact event which threatens the health of populations both on a domestic and international scale, which we can see the most prominent one right now are probably COVID-19 pandemic and climate change. As we are approaching the 1-year mark of COVID-19, it is undeniable that this pandemic has greatly transformed the world within 1 year. Just only last year, in last November 2019, we can see the global population are living their daily life with their daily communication and international travel. Within 1 year, we have seen how the world has transformed. We see that the norms right now have changed into a world where everyone is wearing masks, social distancing is the norm, and there's also a very, very sharp increase in international travel. Even as countries, as of the current status, are rolling out COVID vaccine, it is undeniable that COVID will forever change our way of living. So in this session, we will focus on the digital health. Digital health is the integration of technologies with healthcare system. In this side meeting, we will be exploring how digital health can prevent health emergency from happening in the first place, improve emergency response even if it happened, and mitigate impact from emergencies. We will also be touching on how promoting youth involvement in digital health and digital health literacy will be vital for future digital health progression and sustainability. So our side meeting today have 4 main objectives, which are firstly, to explore how digital transformation of health can influence changes in the healthcare sector. Secondly, we would like to identify the current implications and usage of digital health and technological interventions. Thirdly, evaluate the role of digital health in health emergency. And lastly, recognize how youth and healthcare professionals can increase their capacity in digital health. Before we begin, I would like to thank all the panelists for spending your time with us today. I will be introducing each panelist briefly right now and will give an extensive introduction right before the speech again. So with us today, we have Dr. David Barbe from the United States. He is currently the president of World Medical Association. We have Dr.Priit Tohver from Estonia. He is currently the head of quality services at the North Estonia Medical Center. Dr.Supharerk Thawillarp is the director of Epidemic Intelligence Unit at the Ministry of Public Health in Thailand. And Ms.Egle Janusonyte from Lithuania. She is currently the Vice President for External Affairs of the IFMSA, or the International Federation of Medical Student Association. So let me begin with the format of this session. This session will be this session will comprise of an approximately 7-minute speech by each panelist. We will not be asking any question between each speakers, but we will have a Q&A session, a dedicated Q&A session for 45 minutes after all the speakers have finished with their presentation. I would like to encourage our observer to actively participate in today's session by typing out your question in the chat box below. We can see, you can find the chat box below that there will be a designated Q&A button where you can type the question. If there's any question, please don't hesitate to ask them. And we will try our best to answer every question within this session. So right now, I would like to invite Dr. David Barbe to give his speech. Dr. David Barbe is currently the president of World Medical Association, or the WMA. He has been a member of the American Medical Association, Missouri State Medical Association, and the American Academy of Family Medicine for over 35 years. He was a member of American Medical Association Board of Trustees from 2009 to 2019. He had also previously served as the 172nd President of the American Medical Association from 2017 to 2018. So without further ado, I would like to invite Dr. David to give his speech. Dr. David, please.
Thank you very much. I am very excited to be with you today. It sounds like many of you have had a long day there in Thailand. So I appreciate the time and I'm looking forward to our discussion today. I'm going to give a fairly high-level overview of digital health. I will then give you some examples of how the American Medical Association is approaching this and some surveys that we have done. Then I'll give you a couple of examples about how digital health is being used here in the United States by a couple of different health systems. And I'll wrap up by focusing on how important student involvement is in digital health, and particularly digital health in healthcare emergencies and COVID, as it was mentioned earlier. So I will share my screen and open up my slideshow, maybe. There, can you see my screen?
Yes, it is visible.
Very good. You know, digital health, I think we are in the infancy of digital health, and we are on a very steep part of the learning curve. And digital health has so much potential. As much as anything, it allows us to overcome some of the barriers of geography that we have faced, particularly in countries where there are very rural populations, many people far away from healthcare facilities and services. It helps overcome that distance. It helps us overcome the time that it would take for those individuals to access healthcare. We're seeing enormous strides in portable medical technology so that we can use these digital devices to go to the patient, and I'll show you some examples of that later in my remarks. We also have a tremendous opportunity in what are often called patient wearable devices, things that the patient himself or herself can have that will transmit data to the healthcare team and allow for near real-time monitoring and management of a patient's medical condition. On top of the technology proper, we also have the promise of augmented intelligence. And I hesitate to say artificial intelligence because it sometimes suggests that the computer, if you will, takes over the decision-making process. Both the AMA and the World Medical Association prefer the term augmented intelligence because it enhances what we can do as healthcare providers and physicians to deliver care to our patients, to have real-time decision-making support, to have real-time management of the healthcare data into information that we can use. And if we do that correctly, we can actually anticipate healthcare conditions that are potentially going to happen. We can see some early changes in a patient's condition that allows us to intervene before the condition gets more advanced or more severe. And I'll give an example of that later. What we have found in the United States, and I expect this is true all over the world, is that physicians are ready for digital health, but they are not adopting it as rapidly. And we think there are several reasons for that. And as with any new development, technology or otherwise, the adoption will come in phases or stages. But we're very excited about all of this, and I think you share that excitement. I will show you the AMA's policy on augmented intelligence because it speaks to the digital health and precautions that we need to take. We have to always keep the patient first. I'll let you look at these for a moment. We have to have the voice of practicing physicians, and I would say students and junior doctors as well. We have to make sure that we make things better, not worse, that there's not bias or stigma attached to any of the logic in augmented intelligence or in our digital health devices. And we, number E below, we very much must protect the patient's privacy and preserve security of the data. And as you can see in number 4, we must educate as well as encourage participation in digital health development and augmented intelligence. The World Medical Association has some similar policy and has made recommendations that came out of our October Health Assembly meeting in Moscow. And you can see this. We need to eliminate deficiencies in the provision of the quality of care. And it is not universally appropriate to use digital health. There are simply times when we as physicians will need to see the patient face to face. And we must not forget that. And we need to keep our healthcare assessment and delivery in perspective. The AMA has many resources on digital health, and for those of you who are interested in more information, I encourage you to go to the AMA websites for this. It even has we have a digital playbook. Now, admittedly, this particular part of it is more for adoption and implementation in a physician practice, but there will be links, as you can see in the mid part of that screen, links to many other aspects of digital health. The AMA did a survey in 2016 and another one in 2019, and we see that there has been some progress. The number of physicians that see an advantage in digital tools and digital health has increased. The adoption has grown significantly among all physicians, meaning regardless of their gender, specialty, or age. The adoption of remote care for televisits and remote monitoring is very big and is the area that is fastest growing, as I'll show you. And the awareness of the emerging technologies around digital health and augmented intelligence is growing, and that will, of course, aid adoption, and it will aid further development. The point of this slide is to show the increase in use of digital tools really across all purposes, at least, of course, across 7 purposes of digital technology. And you can see televisits and virtual visits have more than doubled. And you can see that remote monitoring has nearly doubled, although the uptake is still relatively low, but it is certainly increasing. And those are the 2 areas that have seen the greatest increase in their adoption between 2016 and 2019. The physicians also intend to adopt more digital health and to incorporate augmented intelligence to a greater degree in their practices. And you can see here how some are using it now. That's the red bar at the bottom. Some expect to use it. Maybe a third of physicians expect to begin using it in the next year, and another 1/4 to 1/3 expect to incorporate it into their practice in the next 2 to 3 years. I'm going to switch gears now and talk about 3 health systems that have adopted or in the process of developing digital health technologies to augment their care of patients. This is from a publication, an online publication called The Medical Futurist. And this is part of an interview with Dr. Gabor Zato, the CEO of the National Ambulance Service in Hungary. And he sees an immense level of innovation and experience in smart healthcare solutions. He says this is a race against time, and that with these technologies, we're turning patients into the point of care. More care will be delivered at the patient's location or at a remote location from the primary healthcare facility. So instead of the point of care being our office or the hospital, it will be where the patient is. We can get to them sooner, if you will, with digital technology. And he lists 6 areas for innovation, and you can read them there. Logistics and capacity allocation. We can predict where the need is going to be, and we can begin to deploy resources there. There will be apps that will be streaming the emergency care data and activities, so you can be connected to a high-level emergency department, even if you're out in the field, whether it's the emergency medical service or a physician in the field. Video gaming style practice or rehearsal of emergencies, point of care diagnostics. I talked a little bit about that in terms of more portable devices. Medical drones for delivering care and supplies. It's been trialed in some countries, and we can get resources to a patient and the healthcare team in the field faster through the delivery of drones. And then there are transportation opportunities as well, even up to and including a driverless ambulance that can be deployed to a scene much more readily. This comes from a paper, and I know the author, one of the authors, Dr. Thawillarp. I worked with her here in the state of Missouri. There is a tremendous investment in digital health, trying to optimize healthcare, reduce spending, and really what we're interested in today is transforming the care delivery process. And her and the author's area of emphasis here is that while digital companies we need them to participate in this development, without the input of the physician, without the input of the clinician, and I would extend that to students and junior doctors, these tools will simply not serve our needs as well as they could. So I will come back around to that in just a few minutes. 2 quick examples from New York Presbyterian in New York City, United States. This is a mobile stroke unit, and they use both conventional and digital technology in a dedicated unit to go to the stroke victim's location rather than waiting for the ambulance to get there, assess the situation, transport them back to the emergency department. Much of the early care can be given at the patient's home or at a remote location. And that's certain. We know that every second counts when it comes to brain function and circulation. And a mobile unit like this that incorporates digital technology can really be a great benefit. The other thing that this has done, as you can see here, I thought this was just dramatic. It has decreased the time to care from over 2 hours to less than 1 hour. And again, as we know, particularly in certain emergencies like stroke, that can make a big difference. The other thing this points to is the use of telehealth or virtual visits in the emergency department itself. So when a person comes in, instead of going through the normal triage process and being seen by a physician or a nurse practitioner, they're triaged in the same way, but then they're given a virtual visit if their acuity of their illness or condition, injury maybe, is low, and if they don't need to be seen live by a physician, at the bedside. And actually, this slide is a reduction of time in the emergency department with the use of virtual visits. My last example, real quickly, this is my own health system. We have developed an actual virtual care center. It's a beautiful building. No patient ever steps foot in that building. All of the care delivered from that location is virtual. We have virtual ICU, virtual hospitalists, virtual sepsis and V-stroke, V-alert, V-consult. I'm going to touch briefly on V-engagement and V-acute. These are technologies in which we take the knowledge and the medical devices, digital health, to the patient's bedside. We operate the largest virtual ICU support system in the country, and our V-Hospitalist service covers thousands of beds. With V-Sepsis, I talked about anticipatory intervention. We can anticipate when a patient is developing sepsis based on just a few metrics, and can then intervene, start antibiotics, start fluids, start other supportive care much earlier, and the outcome has been dramatic. The engagement is where we put digital health devices in the patient's home of patients that have multiple complex clinical problems. Maybe they've had multiple hospital visits or emergency department visits, and this has reduced the use of those higher levels of care by half by monitoring patients' digital health in their homes. It's a remarkable program. And then last is, and we're going to cut down the use of the emergency department or be able to treat the patient at their own point of care through V-Acute. This supports delivery of care in locations remote from the emergency department and intends to reduce emergency department or emergency room visits, which you can see the advantage of that. So digital health and digital technology has really been a significant factor in those health systems that are ready to adopt it. And then lastly, medical students and junior doctors really are critical to digital health development and adoption. One example is a group called Sling Health. That group was started by students at Washington University here in Missouri, in St. Louis, along with a couple of other groups that you can see listed there that are part of the American Medical Association's digital innovation ecosystem. And if you want to read more about Sling Health, you can go to their website. But they were started as a student-run biotech incubator that provided resource, training, mentorship to teams of students across disciplines, not just medical students, but other engineering and business students. And they have been hugely successful. Their activities have now expanded across 11 states in the United States, and 15 universities are now participating in this. We have been running a series on COVID-19, and this one focused on how Sling Health and other student groups are addressing innovative ways to provide solutions for the pandemic. And I commend this to you. You can see the web address down there. I'll give you two quotes and then I'll wrap up. Dr. Avik Som, who's now a resident physician or junior doctor in the United States, he was actually the founding member of Sling Health in St. Louis. And he says, I think student innovation is so critical because it bridges the divide. The students are often the ones that are willing to put in the legwork, the sweat equity, and so to speak, really get something up and running. So your energy, your enthusiasm, your creativity, your lack of being encumbered by some of the things that might keep me from thinking of a new way of doing things are just exactly what students can do. Another member, the current president of Sling Health, says that students often underestimate the ability they have to really participate in innovation. And his recommendation is have confidence in yourself. And then again, Dr. Som says, be proactive, don't be intimidated. Everybody wants to make it better for the patient. So I know I've gone long. Thank you very much. I look forward to the other speakers. Thank you.
Great. Thank you very much, Dr. David, for your speech. We had learned a lot from your speech, including concrete evidences that you have provided about the AMA and the WMA. I really appreciate that. Next, I would like to invite Dr. Priit Tohver Dr. Priit Tohver is currently the head of quality services at the North Estonia Medical Center, which is the Estonian largest healthcare provider. He had previously served as the advisor for e-services innovation and development at the Estonian Ministry of Social Affairs and an advisor for health, trade, and development at the Estonian Permanent Representation to the United Nations and other international organizations in Geneva. He is the former regional director for Europe at the IFMSA and also a very passionate advocate for global health. So, Dr. Priit, the floor is yours. Please start. Thank you.
Thanks. Do you see the slides all right? Do you see the...
It is visible.
Okay, good. So thanks for having me here. I'm always happy to be at an IFMSA side event talking about digital health and how also youth can help out in this process.
Sorry to interrupt, but your slide is in the presenter view. Can you zoom in?
Let me see if I can fix that. Let me see. Stop sharing. See what I can do. Just a moment. Okay. Is that better?
Yes, it is. Thank you.
Okay, good. All right. So I'm talking a lot here based on my experience as the former digital advisor for the Ministry of Social Affairs and a little bit in my new role as well as head of quality. So first of all, if we're going to talk about how digital health has aided us through this current health emergency, which is COVID-19, then we can't get beyond the basics. There's been a lot of really cool innovation going on within the digital sphere here in Estonia, as also in healthcare, but most of the really important building blocks were already in place before COVID-19, and this is the e-state architecture of the Estonian state, and that really contains of two main services. One is electronic identification. Every Estonian has a compulsory ID card. There are also other ways to identify yourself digitally, like mobile ID, smart ID, but every Estonian has a way to securely identify themselves to the e-state. And this is really their portal to their healthcare data, their tax data. This is where they can interact with government services. This is how the system knows who they are and what they can do. The other really critical service is interoperable data exchange. And for Estonia, this is achieved through something called X-Road, which is an internet-based system of interoperable data exchange, which connects really the thousands of databases that make up the Estonian e-state. So anywhere from the health information system to the healthcare board's information system to the tax board to telecom companies and what have you. Everything is connected via this one interoperable backbone. And we've calculated that thanks to the fact that 99% of queries to the government can now be done online, we save about 3 million working hours annually simply because a person doesn't have to respond to those simple queries, which you can just get at your fingertips in the comfort of your own home. So really COVID-19, a crisis that forces us all inside and makes us unable to go to public spaces and gather, is in a way the kind of crisis that we were waiting for, because we can really do everything from home in this system of government. But these basics are also really important for how we responded to the COVID emergency. So by having all hospitals connected via X-Road, we on the government side, as the decision makers, got near real-time data on hospital capacity, number of patients, ICU availability, everything that you would need to make a decision about do we lock up or do we open up, which we got every morning. And this also, of course, enabled us to communicate with the public as well, and enabled many private providers to build these kinds of public interfaces of government data, so everyone can see how many new infections we have, how many people in hospital, how many people discharged, that kind of stuff. So there's kind of a confidence from the citizen side as well that they know what's going on. But the fact that we have this digital identity also enabled us to start using contact tracing apps, because the big question with contact tracing apps is, how can I prove that I really have COVID-19? How can I prove that I'm not just, messing around trying to scare people? Well, having a digital identity, this kind of really secure way of saying to the system who you are, and allowing the system to check if you really have that diagnosis attached to you, is what made that process really secure and trustworthy. And immediately during the first wave, when we had to close down, a lot of schools the first time around, it was really important that we had the state portals at home. So, for example, if parents had to take care of their children because they could no longer go to school, then they could just apply for parental leave at home without rushing to the GP's office or without overloading the GP with queries all of a sudden. So they could do this in their own time, and the GP would have like a week to check through these kinds of queries. And moving forward, this e-state backbone is also going to be really important for when we roll out the vaccinations, which start in about 6 days. So having an overview of who is vaccinated and who is not is something that we can now do, or thanks to the e-state architecture that we have in the backdrop. So that's the basics. But there was also a lot of interesting innovation going on, things that we'd never done before. So Estonia is, I think, has one of the highest number of startups per capita, if not the highest in the world. And our approach to how can we come over this crisis was very akin to that. So we had a hackathon, basically, for people to come together and figure out solutions that would help smooth the transition into COVID-19 and into this kind of new lockdown economy. And there were really a lot of really interesting solutions that came out of this hack. For example, new designs for respirators, which were low cost, new visors, that kind of stuff. But also a lot of digital services. So one thing that I myself developed as a part of this hack was a online symptom checker, because we had the issue in the beginning that it was very hard to get testing. GPs were very overworked answering questions. And so we just did this digital coronavirus questionnaire, which just told you whether you should either contact your GP or stay at home and monitor your symptoms, call an ambulance, that kind of stuff. But it also gave us something interesting. So we could also ask participants, where are you now? So if you're, for example, reporting symptoms, we could get data about where new potential outbreaks might be coming from. And since this was open source, we could easily also provide the same service to other countries. So for example, the Maltese government took our questionnaire and adapted it to their own needs. So you see the Maltese questionnaire on the right, and it was actually another IFMSA colleague leading that effort. We also developed something that came out of the hack, was a database for volunteers with medical experience, because this is something that hospitals needed. They were really overworked. So a group of people developed this online environment where you could register yourself and you can say what kind of skills you have. Like, for example, I'm a medical student. And then hospitals like ours in the North Estonia Medical Center could then send out requests to this database. So we need so and so many people with so and so many skills, and then they could confirm or deny whether they were willing to help us in that situation. And for example, when we're trying to man a remote hospital in one of our islands, we could do that in a matter of hours using this database. So that was great effort. Another thing which didn't come out of the hack, but which took us, but which was a good example of how private companies and the government can work together, was our own contact tracing app based on the Google Apple API. So this was done completely free in a consortium of about 12 different companies working with the ministry and with the Estonian Health Board, and which is now, it's reached about half of its potential users in Estonia. So we still have a way to go. But the uptake has been good. And by now, contact tracing notifications are increasingly coming from the app and not from manual contact tracers, but they are meant to be synergistic efforts. And finally, I'd just like to finish off with what I consider to be the role of youth in rolling out digital health and helping out using digital health in healthcare emergencies. So first of all, we've already seen the role of youth here in Estonia. Many medical and nursing students volunteered through that database, which I just showed you, or participated in the hack and developed a number of useful products, which the government went on and used. And what I've seen, both working at the ministry and as well as working with junior doctors at our hospital, is that young people tend to be more likely to adopt digital health and new innovative solutions, new ways of care. And this makes you very, very important to the continuous development of healthcare, because you haven't been in this mix for as long. So you see it with new eyes, and you bring to it the kind of tools that you've grown up with. And this really allows innovation to happen in healthcare. It allows us to do things differently because we have that massive early adopters, which often are, but not always are, of course, young people. And this is why we're also always very happy to include youth when it comes to piloting and testing new solutions. More often than not, they volunteer themselves. And a question that was raised was something down the lines of how can youth be better prepared for using digital health. And I think on the digital skills side, youth are doing just fine. Often they would be the one teaching more experienced doctors on how to use different digital technologies, while the more experienced doctors teach them about various aspects of how to carry out the medical care. But one thing, if I had to make one suggestion, I would teach critical thinking around digital health at the same level as we teach it around evidence-based medicine. And what I mean is that we have a way of assessing the evidence in medical science. We are able to analyze the methodology of a kind of study, where it has been published, how many people it included, what is statistical significance. We have that tool set to understand what is an actual meaningful medical discovery and what is perhaps just a headline. But for digital health, we don't have that as much. And it's not the same tool set, but it's the same kind of critical thinking that I know medical students are able to do. So if I had to put an effort somewhere in the digital education sphere, I think this would be it. How to better detect meaningful digital innovation from something that is maybe just an expensive headline. And my final posit or question is, how can we create environments where junior doctors and our junior colleagues are heard? And this is, of course, not a matter that just affects young doctors. This is a matter that also affects nurses. It affects anyone who isn't part of senior leadership in a hospital environment. Because when you see something which you're not really happy with, or where you see that there is room for development, there's not always the space there for you to make the suggestion. Sometimes that suggestion can be taken as offensive or as criticism or something like that. And we as hospital leadership really do have to look inside the culture that we are building to make sure that every voice, including our junior colleagues' voice, can be heard. And what kind of changes do we have to make within our culture to enable that? Thank you.
Thank you very much, Dr. Priit, for your speech. You had mentioned a lot and illustrate to us how Estonia is doing right now in this COVID pandemic. You had already illustrated to us how they are using the contact tracing progress with both the healthcare sectors and the governmental facilities. So next, I would like to invite Dr. Supharerk. But before I invite Dr. Supharerk, I would like to encourage our audiences to submit their Q&A session in the Q&A section below, and we will get to them once all of our panelists finish with their speech. So Dr. Supharerk Thawillarp is currently the Director of Epidemic Intelligence Unit at the Ministry of Public Health in Thailand. He is a senior professional level medical doctor as well as a preventive medicine specialist. He also had previously worked with UNICEF in the development of HIV dashboard and indicator for monitoring HIV progress in Thailand. So Dr. Supharerk, please.
Okay, sure, thank you for instructions. Let me try sharing my screen. Hold on. So everyone's...
Yes, it is visible. Thank you.
Okay, thanks. So because we already mentioned several things about the medicines in the hospital, because I'm more like a public health sector and epidemiologist, so I will take you a little bit out of the hospital to the public health field a little bit. So in this sessions, I will introduction about the public health emergencies. So first, what is the public health emergency? So that's the term defined in the Internal Health Regulations 2005 as like an extraordinary event which is determined worldwide in the regulations, which you can read.
I think your connection is unstable. Dr.Supharerk, are you with us?
Can you hear me?
Right, can you repeat the part? I think your connection is unstable.
Yes, because I was being deployed to the field, so it's not good. So yep. So the public health emergencies is the terms that an extraordinary event that risk of spreading across the international borders and require the coordination between across several countries. And the one who make the decisions of that events is the WHO Director General and their committees. And I think everyone already know we are in the midst of the coronavirus health emergencies around the world, but this is not the first time that we have this kind of event. We have swine flu in 29, polio, Ebola, Zika, Q Ebola, and of course the COVID-19 is our largest emergencies. And of course, every single time that this kind of events happen, the chaos, riot, and unrest will happen all around the world like we are seeing at this moment. But it's not just the citizens and people that was frustrated. We, the physicians, as you already know, the emergency room was filling up, the ward and the bed capacity were filling up around the world, and we have to running around and work wanna stop more than 2 or 3 days. So because many of you are medical students, you don't expect you to have the direct experience onto this, yes, but just things that suppose you are in the midst of the mass casualty accidents. And there's many people crying for help. They are injured. They're bleeding severely. If 1 or 2 people, then yes, you can manage to do that. But what about 100? What about thousands? When that time comes, do we have several questions popping in your head? What is the situations? How many patients? How many injuries? Who made decisions? What am I supposed to do? What am I supposed to talk to? And how many medicine? How many supplies do we have? And where to get them? This will happen all the time when you face these kind of situations. So, and of course, the key thing is to bring the order to chaos. How? So it's more like a chain of command. The chain of command is like you have a very clear protocol. You have a very clear responsibility on who to do what and who to talk to and who to make decision and who to report to during the incidents. And what do I mean by that? So I think many of you have seen these pictures before. It is the NASA Mission Control Centers, which is control the missions of the spacecraft. The command center will gather several information into this room, display on the board, and everyone in this room will make a judgment, analyze data, and make a decision like to deploy a team. And of course, the team will be deployed based on the decisions made in the room on like which area and what kind of interventions they need, so we can utilize our resource to be the most effective. So because we already have too much of the COVID-19 right now, I will take you a little bit in the past to see the Ebola events. I obtained some of the material from my friend at US CDC, Anthony and Christine. I already mentioned about the NASA Command Center before. This one is the real pictures at the US CDC Atlanta headquarters. It's the Emergencies Operations Center. As you can see, there's a lot of information scattering on the monitors in the room, and people will gathering data and make decisions based on their roles. And then all the hiring staff will get in the room with their information and then decide on what to do and who to be deployed to the field. And at that time, well, my friend was deployed to Liberia to control the Ebola. And you can see that there's a riot, there's a protest in that kind of situations when police try to control the crowd. Again, this is a very familiar image, but this is Ebola, not the COVID-19. And they also do the case investigation and contact tracing, which is very challenging at that kind of situation and in the very rural area of Liberia. And they had to gain access to a very remote area using by helicopter and put them into the self-isolation facility with they use a tent, just a tent here in these pictures to quarantine people. And this is what they find in the local facilities. The left-hand side on this picture is an actual medical record in papers, and you can guess it's pretty messy and very hard to obtain the right the medical record, and it's very risky of losing the data. The right-hand side is the graph of the data system on how the medical record flow from one department to another. Well, you can see it's very, very complicated and very hard to catch. And of course, when the data loss happen, it's very hard to track down on the cost and how to solve it. So in that time, the company named Tohver came to and designed the digital solution to help the Ebola facility using the tablet with collecting the data of the Ebola patient in the facility. It's much better than the satellite line. The tablet and the solution and the applications were designed specially to use in the Ebola facility. Even the staff was wearing the PPE. Again, this might look familiar, but this is Ebola, not the COVID-19. So a bird eye view of this picture is like we use the technologies to gathering data and feed it to the command center, where people, the decision maker at the center, will analyze the information and make decisions and make order about the interventions and the field team to be deployed. And of course, which it's Dr.Priit and Dr.David, we already talked about, this kind of crisis always drives transformations and disruptions. And of course, telemedicine is one of the most important disruptions at this moment. This graph I obtained from the New York Presbyterian Hospital. Before the lockdown, we don't have much of the telemedicine visit. But in March, the telemedicine visit spiked and remained very high even after the lockdown has subsided. And of course, this picture I got from the Stanford Children's Hospital. At that time, when they issue the lockdown, they have like a very limited time, so they have to deploy the telemedicine using the resource they have. They install the Zoom applications on the iPad tablet and put it on the roller wheel, and you can see this picture. And they also use the tablet for their patients to communicate with their family. This is in Thailand. We also use similar approach using the tablet. As you can see this picture, the doctor outside of the quarantine room use the tablet to communicate with the patient inside the negative pressure room. And not to mention about that, there are several innovative contact tracing apps. As this picture is from the NHS UK and from Singapore, which use the Bluetooth algorithm to track the COVID-19 patients. Because this conference is about the medical student, so you may ask, so what about the role of the medical student in this crisis? Unfortunately, I would say that because the medical school don't want to risk medical student in terms of infecting the COVID-19, so right at this moment, we don't see any direct involvement yet. But as you can see in these pictures, there's some states already call out like a medical student to graduate early to help them fight the COVID to fill the workforce. And some states like Johns Hopkins or the Cincinnati School of Medicine has called the medical student to help the senior, the elderly, like to buy them groceries to pick up their the medicine and give them at home because they could not go outside during the lockdown period. And come with the next questions. What can we, the young medical students, do to prepare ourselves in the future? First, please study and make sure to graduate, as of course. And the second is to try something new. What do I mean by try something new? In this slide, I show you there are several applications like Telegram, the File Chat, Asana, and Zello. which I used during the field investigation outbreak. I didn't know aware of this kind of application before, but it was recommended to me by my younger generation, because they tend to like a very familiar and know a lot of the tools, a lot of very new applications than I do. So they can recommend me to, okay, this app might be suitable for your work. And that's helped me a lot during the field trip. And of course, there are several health tech startup, which most of the founder are also the medical student that have like innovate several solutions to help the world solve the problem, because you are more very creative than I do to up this kind of events. And if you think it's too big for you, think of this person. I remember that during the introduction section, you talk about the climate change. This girl is Greta Thunberg. She is 17 years old, younger than most of you in this room. And you know how huge is your success. So I would end my session with this word: you are never too young to change the world, and I hope you all will do. Thank you.
Thank you very much for your inspiring speech, Dr. Supharerk. You had illustrated to us the importance of data management. You had shown us how it looked very much the same between Ebola and COVID-19, which is years difference. So you had already shown us why it is very important to improve on the data management. Next, last but not least, I would like to invite Ms.Egle. Ms.Egle Janusonyte is the elected Vice President for External Affairs of the International Federation of Medical Student Association. She has represented medical students worldwide in international meetings, including World Health Assembly, World Health Summit, and WHO Regional Committee for Europe. She has also previously acted as Liaison Officer for Sexual and Reproductive Health and Rights issue of the IFMSA for 2 years. So, Ms.Egle, the floor is yours.
Thank you so much. It's a pleasure to be here. So hello to everyone who is attending this panel. My name is Egle Janusonyte. I'm currently a final year medical student from Lithuania and also in office as IFMSA's Vice President for External Affairs. So the International Federation of Medical Students Associations is the world's largest and also oldest student-led organization. And in this talk, I will be briefing you about the status of medical education and digital health. So for my talk, I also will not be using any slides. So we can start. The very first question, or maybe thought I would like to put to your heads, is actually an object, a kettle. So I would like to ask you if you could imagine a person who is seeing an electric kettle for the first time in the year 2020 without any instructions, and what this person would do to boil the water. So a potential answer is that this person might put it on the stove and try to heat it like it was done for the hundreds of years. Now, what if I would ask you what happens if medical education faces digital means of facilitation for the first time in history because of a healthcare emergency in the same year of 2020? I think for sure we can say misconceptions and errors are inevitable. So how educational institutions that are preparing the health workers of future should stay up to date with the rapid development of technology and digital health? The intuitive answer does seem to be that we need to update the curriculum and promote continuous professional and interprofessional evidence-based education. We also have to focus on digital health literacy competencies. Now, I would also like to ask you to picture a final year medical student. So today, most of the final year medical students in the world, the future health workforce that are about to graduate, are in between 24 to 26 years old. Some may be older, some are younger, depending on the medical education system around the world. I think it is safe to say that we are the first generation of young, almost doctors in human history to have grown up in an environment which is full of digital interventions. And technology being something so mundane, I don't really think many of young people give a second thought about it. So it would make a lot of sense if it was our generation of healthcare professionals that would completely normalize the use of digital health in clinical practice. But where exactly do we stand now? So to illustrate this and also get a bit back to healthcare emergencies, on the onset of the pandemic this year in early spring, IFMSA has carried out a survey in which we attempted to track the status of medical education during the pandemic. So we developed a tracker which was distributed between our national member organizations that represent more than 1.3 million medical students worldwide. Our results showed that actually more than 2,600 medical schools around the world in almost 100 countries went through complete suspension of physical education delivery. It also meant clinical rotations were not happening, and definitely this is something completely unprecedented in medical education. And out of this number of schools who suspended the education, so it's 2,600, they actually followed up, 1,120 followed up by completely switching and delivering medical education content in digital platforms. So we now have examples of students who have graduated or maybe passed a certain year of medical school by learning exclusively through online tutorials, online clinical case discussions, and even simulations through a large variety of different digital platforms that include the Google Classroom, Zoom, Microsoft Teams, and so on. I'm absolutely sure that everyone has heard all these platforms so many times during this period of time. All that could be used to stabilize the status of medical education was used. And while the situation is for sure not ideal, as medicine is undeniably based on human contact in many cases, the student attitudes to this change were very positive. Online lectures, demonstrations, also maybe worth to mention e-learning resources have taken precedence over any other learning methodologies this year, and they are well accepted by students. But two conditions have to be present. So the first condition is technicalities, so there has to be internet access ensured. And secondly, the professors have to be trained to use this technology. What we have assessed as IFMSA from this situation is that thanks to technological advancements, actually we can adopt such innovations to supplement the routine medical teaching even in the post-pandemic settings. From such results and students being very keen to such models, it seems very evident that young future healthcare professionals are capable to learn how to apply digital health interventions and maybe how to innovate for better solutions to improve health outcomes of their communities. And we can start from e-health records and go to maybe even prescribing apps someday, for example, to monitor elderly patients whose falls may be monitored through a smartwatch. However, it is important to say that at this moment, there has been no evaluation of digital health in medical curricular research carried out on global level. But it can be suspected that likely it's not a permanent curriculum topic in the majority of medical schools. There are some significant papers that detail some of the gaps. Most of this research has been carried out in Europe. And there are some small-scale findings that medical students rate their digital health skills as poor. However, larger-scale research is at the moment a gap. For this reason, IFMSA is now developing a survey to collect data on medical education and digital health. And we will be launching this survey to try to fill in this gap and provide clarity in the actual status of digital health in medical curriculum. For us, it was, I think it's extremely interesting for all IFMSA members also listening to this panel to hear the insights shared by other speakers. And we hope that by creating overview of the current reality, we can work towards significant improvement. And just a few final things before I finish, I wanted to share with you some examples of how people that I personally met as my classmates and my colleagues in medical schools are already shifting the future of medicine. And to tell you the truth, I didn't have to look far at all. For instance, my colleague in the same school year is now a part of a startup which is developing smartwatch solutions to monitor safety of people living with dementia. Another person, final year medical student, is leading the development of machine learning based algorithms for more effective health ultrasound diagnosis. And of course, it's true that we have yet to see if these projects will develop into meaningful digital innovation and perhaps not be just fancy headlines, as Dr. Priit mentioned. But what I want to say, even though at the moment I cannot speak on behalf of other countries, I know for sure that in Lithuania, my home country, digital health is not really prominent in our education. Yet there are already innovative people who, regardless of this gap and never formally learning about it, are already coming up with interesting solutions and being creative. And I would like to echo that it's definitely true that young people already have the digital skills, but we need to harness these digital skills to deliver digital health and to learn more about itself. Therefore, I invite you to imagine a future where every healthcare student receives a strong foundation in digital health. And I do hope it's a very near reality for the world. And I also invite you to connect young people and their experiences with the evaluation of education today. And perhaps we can boil this kettle in the correct manner and improve health for all. Thank you so much, and I look forward for the discussion.
Thank you very much for sharing your insight within IFMSA, Ms.Egle. I totally believe with you that I totally agree with you that right now is the best time to change into moving into the digital part and into the digital health. This may be actually be the time of the decade because the situation is really, really nice for moving from an on-site into a digital world. So right now we will be moving on to a Q&A session. Right now we have a few questions from the audiences. I think this first question is addressed to you, Dr. Priit. The question is, isn't e-identification more susceptible to identify theft and privacy invasion? How does the system overcome these challenges?
No, I wouldn't say that it is particularly susceptible to identity theft, because it's not just, e-identification is a far more complex type of cryptography than something like identifying yourself by means of a password or something like this. So not only do you need the physical medium, which is the identity card or the mobile ID, which is in your mobile phone and linked to your person in particular, you also have a system of PIN codes, which you have to enter whenever you are trying to identify yourself. So it is actually a very secure way of identifying yourself. I mean, technically you could add a third layer, which is biometric, but we think that the expense of that kind of technology versus the limited amount of security that it adds is just not worth it. But every country can draw the line where they consider the level of security to be all right.
Right. Another question has a follow-up question on the same topic, so I'm going to address to you right now. So the question is, where do we draw the line between the national security and data privacy?
Well, ideally, you wouldn't have to draw the line at all. I can give you one example of how we developed the contact tracing app in Estonia. There we had immediately the first question about what is secure enough. How can we be sure, for example, that someone who reports themselves as COVID positive really is COVID positive? And we considered a number of different ways to do this, from just having someone give you like a barcode to scan, to the system of e-identification, which we eventually adapted from the Estonian e-identification system. The e-identification solution was far more complex, took far longer to actually implement, but we considered the gain in cybersecurity to be worth that kind of addition of time. But at the same time, sometimes you do have to draw the line somewhere. But if you have a functioning e-state architecture in place, which already has that level of cybersecurity around healthcare data, and you don't have to start developing something on the spot as soon as an emergency hits, then most likely you will not have to do any kinds of corner cutting when it comes to people's cybersecurity, because the cybersecurity infrastructure is already in place by that time. So the way you do this is by actually preparing yourself long before this kind of a pandemic or ever health emergency hits.
Thank you very much, Dr. Priit. Do any other panelists want to have an input in this question as well? Dr. David, do you want to have a go? The question is, yeah, I can repeat the question. Isn't e-identification more susceptible to identify theft and privacy invasion? How does the system overcome this challenge?
So it's interesting, de-identified data is not as secure as we would like to think. It doesn't take but 2 or 3 data points for an artificial intelligence or augmented intelligence program to figure out who the individual is. But I agree with the previous speaker. If we do this correctly, the privacy will be as good as it can be. Now, if you think back to the old days when we were all on paper, that data isn't fully secure either. So we can't let perfect be the enemy of good. And right now we have good data security. It can be better. There can be better encryption. There can be better keys to unlock it. We can have better control over who has access to that data. But right now, the data is fairly secure. The other thing that we must have, and this is part of the AMA's policy, is that we must have validation from the software developers and the hardware developers that they can demonstrate adequate security and encryption. So that's all really important. I would say, and jumping maybe to a different question briefly, there are two questions that I think work together. One was about how do we get digital health into settings where digital resources are scarce or limited? And the other question is, what should the government role be?
Sorry, actually, we are moving on to that question. So I think I can read out that question. And I think this question is not addressed to any specific panelists. So I would like an answer from our panelists, starting off with Dr. David, then Dr.Priit, then Dr.Supharerk, and Ms.Egle, please. The question is, how will digital health happen in settings where digital resources, for example, access to internet or associated resources are limited? Dr. David, please.
Sure. And I'll be brief. This is of high concern to the World Medical Association because so many of our members and so many residents of the world live in places just like that. This is where the government has a very significant role in improving infrastructure for cellular or internet connectivity, because everything is moving digital, not just healthcare, everything. And for residents of the world in underdeveloped countries to stay connected and to take advantage of the modern amenities we have in healthcare and others, there must be an infrastructure, and that is clearly government's role.
Right. Thank you for your response. So moving on to your take, please, on this question, Dr. Priit.
So first of all, every government definitely has to work with the capacity that it has when it starts to develop digital health. There's no point in just rolling out digital services which are only for the selected few. So regardless of what the limitation is it internet connection, is it digital skills, you're going to have to tailor your digital services accordingly. And I agree absolutely that as a government, you do have to worry about how you get that connectivity, particularly to areas of interest like hospitals, or how do you ensure cellular coverage. And this is why digital health should never be only a matter for ministries of health. You know, it should be a group effort with ministries of communication and economics and finance, because you need the same infrastructure that you have in place for digital health, you need for other areas of digitization, from your ports to your tax ports. But also you can sometimes build services around the limitations that you have. For example, the Estonian e-prescription service doesn't require anyone to have internet connection or even a digital skill set. As long as the family doctor or the hospital is able to do the e-prescription and the pharmacy is able to receive it, you as the patient don't have to have any skills. You just go to the pharmacy and everything is done for you there. You just have to identify yourself using any analog means. And I've always been inspired by the example of the Aravind Eye Clinic in India, which has managed to really, put a dent in the issue of blindness among adults. And one of the ways that they do this is by having these mobile remote care clinics. So they go to less served areas that don't have internet coverage or cellular coverage. and they bring the clinic there and then transmit back to their centers of excellence. So I think there are good examples also in developing countries.
Right. Thank you very much. Dr.Supharerk, can I have your take on this, please?
Okay, sure. Let me bring some slide real quick. Because the question is about the development of the e-health in the developing countries. Can you see my slides now?
Right, it is visible. But I can't hear you right now. I think it might be a problem with your connectivity again.
Oh, hello.
Can you restart, Dr.Supharerk? Yes,
Okay,
I can hear you right now.
Yeah. Okay. Can you hear me now?
Yes.
Right. Okay, great. So the terms mHealth stand for the mobile health, which use like a phone, but before we have smartphone. 5 years ago, my advisor sent me to Africa. This is my car here in Kenya. At that time, this is the hospital there. This is from the UNICEF. They already have this kind of the project, like there are several hundreds this kind of the let's call it e-health. So what did they use in that area? They use this kind of feature phones and the SMS, the short message service. For example, this is an mHealth in India, which is called Mama. They use the SMS to send a message to the mothers of how to care their baby. They send a reminder to the patients receiving the prophylaxis of the HIV. This project sent also the SMS sent to like a stock checking of the malaria prescription drugs. And this is the another one using the feature phone. They use the usage is similar to the clinical decision support, or which Dr. David called the augmented intelligence, but they just use the feature phones. They input the symptom of the baby, and the phone just give him on how to treat the baby using this feature phone. This is a real pictures taken from the Malawi. And this is from my country, Thailand. So they just use this cheap webcam, plugging the plastic drinking water onto the very cheap microscopics, and they just send like an image and consult to the pathologist at the regional hospital here. So the tech is it can happen. You just realize on what you have there. It's possible. Thank you.
Thank you very much, Dr.Supharerk, for concrete evidences of how it can be applied by using digital health, even though there isn't or very low internet connectivity. So next, Ms.Egle, please.
Thank you. Actually, already many important insights were shared, so I will just piggyback and say that in this case, I would advise youth. Well, of course, youth can always advocate for the inclusion of these services, but it's also time to hold governments accountable, because in this case, we would need governments acting up. Thank you.
Right. And there's a next question directly addressed to you, Ms.Egle. It is, could you give more details about the survey organized by IFMSA on digital health?
Yes, of course. So as mentioned previously, the purpose of this survey is to evaluate the current situation on digital health and medical curriculum. It is not a topic that, according to our observations, has been touched upon by research at the current moment globally. What we're doing right now is that we are collaborating with several global health stakeholders worldwide, and we are consulting on how this process should go and what are the most pertinent issues that we should touch upon. So, for example, even from the questions asked right now, privacy is something, and privacy and data collection is definitely something that can be mentioned in the survey. So we are still defining our core areas. But the ultimate outcome of our survey will definitely to see if we can bring changes and to accelerate the digital health inclusion into medical curriculum, because I do think that at this point, with technology advancements, it's inevitable and it's just a question of time when it happens. Thank you.
Right, thank you very much. So due to time constraint, I think we will be answering two last questions. And this first question will be addressed by our panelists in the same order, please. So the question is, what should be the government role if they would like to support the digital health sectors? Dr. David, please.
So I think there are two things. We have already talked about infrastructure. The second part would be potential incentives for the government, for developers to develop in the digital health space. There can be tax incentives, there can be competitive grants. There are several ways that a government can help. The third way is by proper regulation, but not over-regulation. You over-regulate any sector, you get less of that. So proper regulation, but not over-regulation is important. And then a Ministry of Digital Health or Health Informatics can be very helpful, and that gives credibility to the government's interest in seeing digital health and other digital solutions develop.
Right, thank you very much. Dr. Priit, can you answer this question as well?
Yeah, so again, I've been pushing the point of infrastructure, and what governments really need to do is understand that there is no digital health or digital courts or digital economy. It's all one big digital state. So definitely, digitization needs to be a team effort, and governments need to look into ways that they can make the most out of this joint infrastructure so that you don't fragment your budget and so that you really make the most of what healthcare can be, because healthcare is not just what happens in a hospital or what happens in a GP practice. About, 40% or more of your health outcome comes from your health behavior, your socioeconomic background. All of this factors in to healthcare decision making. So if you don't have an interoperable system between the social and the health and the economic sphere, then you're missing out on a lot of important data. And if I would specifically address ministries of health here, or ministries of social affairs as we have in our country, then I would really stress that you can have a separate digital health department. We also have a separate digital health department, but make sure that the digital health department and the health department have the same goals and the same agreed upon strategy. Because what I find is that if the digital health department moves in one direction or at one speed and the health department works at another, it's often digital health that loses out, because digital health has not been tailored to serve the real health need. But if you have the real health need and the digital as a means to achieve that, then you can really achieve great things.
Thank you very much. Dr. Supharerk, please.
Yeah, sure. Actually, we are pushing the same kinds of the digital health innovations here in Thailand, and one of the most challenge is the regulations, as Dr. David already stated. And one of the important regulations is about the privacies and confidentialities. There's many startups that have been trying to work with us, but we stuck with the deep let's say controversies of the privacy. So when they, for example, they want to train their artificial intelligence, but they could not access to the medical record regardless of what we have. So we are trying to achieve that by trimming out the regulations. So that's the first thing. The second thing is about the infrastructure. And let's say it is a network. If I remember correctly, in the at the American Medical Association, there's a project called the Physicians Innovations Network, which connect the physicians to the innovators, which is very great. And we are trying to do the same thing in Thailand, because we have this problem, we have this pain point, but we could not find the developers or any co-founders or anyone with capacity to develop the products. So in overall, I think the government should support the two things, the regulations and the infrastructure. Thank you.
Right. Thank you, Dr. Supharerk. I think for that problem, I think you can contact Dr. David for that point. And lastly, Ms.Egle, please.
Thank you. So just to take a slightly different direction, I would like to emphasize that if governments, by taking this more proactive role, would like to have young people as some of the main stakeholders and actively engaging in also digital health interventions, it's extremely important to ensure meaningful youth participation and to make space for youth at the table to actually make meaningful and non-tokenistic contributions. So having youth is not in that case an option, it's a necessity. And I really hope that this can be considered strongly by all governments and all stakeholders who are considering moving digital health forward. Thank you.
Right, thank you. As we are running out of time soon, I will be taking one last question. As this one is regarding about medical curriculum, I will be asking Dr.Priit and Ms.Egle, starting off with Dr.Priit first. So the question is, what is the possibility of digital health emerging as a field or a part of medical curriculum, and what would be needed to achieve this? Starting off with Dr.Priit, please.
So digital transformation of healthcare or healthcare technology actually is its own specialty in Estonia. So if you're interested in studying it, we actually have an English curriculum in the Tallinn University of Technology. It's an MA. And I know healthcare professionals that have taken it separately after medical school, for example. Digital health as a part of the medical curriculum is definitely more difficult. I've actually heard that there's a university in Russia which apparently teaches like a parallel degree where you get a medical degree and then you get a healthcare informatics degree at the same time. Apparently it has a huge dropout rate because the stress is just too much to take these things all at once. But I mean, as a minimum, I mean, you should have a semester on different ways to innovate within healthcare. It doesn't have to be digital health, or as a part of healthcare economics or something like this. So at least medical professionals should acknowledge the fact when they're being trained that their medium is moving more and more digital. They should acknowledge the reality of augmented intelligence, as was pointed out earlier, and really prepare for that. And prepare for that in a way that they're also able to assess these kinds of technologies and perhaps also engage with these kinds of technologies in their development phase, because it's really important, as was also pointed out by the WMA, that healthcare professionals are actually a part of this development. It can't be done by IT professionals alone.
Ms.Egle?
Thank you. Well, actually, when Dr. Priit was speaking, I was just imagining that a semester of digital health course would be something amazing and something that I would love to have had as a medical student. Talking about the medical curriculum, ideally, what could happen is that when medical students notice there is a specific gap in their skills, they communicate and give this feedback to the university, and then we see change. However, in reality, this process is very often impeded by different bureaucratic procedures, and it sometimes takes quite a long time until we see some sort of tangible change, especially when it's something, I would say, considerably as big as a new subject to the medical curriculum. So even though I believe we should advocate strongly about it, and I hope it's easier once we have data about it, I also recommend that medical students take the initiative also themselves. In IFMSA, many medical students take up non-formal education and also build each other's capacities in order to fill these gaps in the curriculum. But I do hope that perhaps this half semester teaching is a very near reality for us. Thank you.
Dr. David, do you have any input?
Yes, real quickly, I want to show the group this slide. The AMA has published a textbook called Health System Science. This is the second edition. You can see the table of contents at the bottom. It is not all digital health or informatics, but it gives medical students a broad exposure to the things outside of your direct clinical learning that are critically important to being a well-rounded physician, but also to be an active participant in shaping the health system in your country. So I commend that to you. It's available to buy on Amazon. And many medical schools in the United States are using this as part of their curriculum.
Right, thank you very much, our panelists, for the input. Right now, as we are wrapping up the session, can Dr. Supharerk, do you have any last input before we wrap up? Yes,
Yeah,
please.
sure. Yeah, sure. Because the last questions are about the field. So I have to say that there is a field, but after you are graduated, it's called the health informatics. Because I myself, I am the health informatics graduated myself, and also the clinical informatics is considered as the subspecialty in the United States. So to answer the question is yes, it's now a field.
Right. Thank you very much, our panelists. As we are wrapping the session right now, can our staff team open up the QR code? So we will provide a QR code for the session feedback. So I would like to invite all audiences and all observers to submit feedback to our session, so we know where we can improve for our upcoming session. And as of now, I'm going to make a brief summarization. So I think in this past 1 hour and a half, we had learned a lot about digital health. What about the definition of the digital health, our current progress in the world right now, both in the United States, in Estonia, in Lithuania, and in Thailand. We had learned a lot about and had been given various examples, various concrete examples on how the digital health can be applied in real life. But I think what actually sum up this session best is the quote from Dr. David that we have said that physician is ready to apply and use digital health in our life, but the process is now being adopted slowly. We can see from many question and answer from the panelists that the process are having lots of processes, and we are currently going on with those processes. There are certain regulations needed to be done by the state, and there are also needed some incentive to help the private sector to succeed in this, as private sector alone definitely can't do this without the help of the government. And the government, and this is going to be a team effort between the private sector and the public sector. And the public sector will not be exclusively related to healthcare system, but it will be related to the government as a whole. We had also got great input from our panelists, how medical students and youth can be engaged in digital health. So I would like to encourage all listeners and our observers who are youth to believe in yourself and believe that the digital health is going to be evolving into our life really soon. So we need to either adapt to that, and we have to learn about the digital health and incorporate that into our life. So I hope by now all audiences had either scanned the QR code or take a screenshot to submit the form later on. Lastly, I would like to thank a lot of people. So firstly, I would like to thank the PMAC Secretariat for helping us along with this session. So they help us making this session achievable and successful. So thank you, the PMAC Secretariat, for that. And also, very importantly, all of our panelists, thank you for your time, for joining our session. Thank you for giving a great speech by all of you and a great input for the Q&A session. And we would also like to thank our observers and audiences for coming and tuning in to join us today. I really appreciate that. And I also appreciate various questions. We had received numerous questions that we can't actually answer all of them. So thank you very much, everybody. And please scan this QR code for the last time so we can improve for the next session. Thank you very much. I will be leaving this QR code on for another 30 seconds. Thank you very much, everyone.
Park, if it is possible, can all of us take a picture?
I think our panelists, some panelists has already left. I think that is fine. Or
we can just take a group photo right now, just for the sake of memory.
right, sure.